discipline of health and migration, transcultural nursing and refugee healthcare. So as you take your seats, can I please invite you to welcome PJ.
Thank you very much. Okay, so I feel hard done by that there has been no coffee, and not through any fault of the organisers, I'm sure, but I'll try and keep you awake. I know we're on the last lap, and I'm delighted to be asked here to speak today and congratulate HIV Ireland on 30 years of excellent work in community across the HIV sector. My own relationship with HIV and HIV Ireland in the old guise of Dublin AIDS Alliance was when I started working as a nurse specialist in Parnell Square before we moved to Balseskin. I was there in 2000, so I feel I'm over the halfway edge of 30 years. So I have a pain in my head from this morning just thinking of all the history, the work, the connections, the reconnection I'm doing today, and it's great to see it continuing. My work around HIV is very limited. I'm not a HIV specialist in nursing or medicine in any way, but I do work with migrants, and my cohort of migrants is refugees and asylum seekers. And my interest in HIV kind of came about in my early days in nursing back in Cork University Hospital, or the regional as it was then, back in 1989, looking after a young man that had come back from New York. And the history that has been spoken about today, the negative aspects of that have resonated with me as a nurse. I then worked for a little while in Haiti in the early 90s and got interested in pediatric HIV and came back and did my children's nursing. But what really sparked it was reading of a book some of you may know back in 1989 called Beyond Love by Dominique Lapierre, the same author of The City of Joy, where he was looking at the social, political, cultural aspects of the emerging epidemic of HIV. So basically what I'm going to look at today is really looking at the whole area of migration, the impact of that in Ireland in the context of HIV, based on our own experience in the clinic in Balseskin. We're all aware of what's happening really in the Mediterranean and the Irish government's response to that in the context of bringing people into the country and keeping them safe, number one, allowing them the opportunity for seeking protection regardless of what their reasons are, particularly in the context of the Syrian war and the establishment of specific programs around that. Just looking at the background for today and looking up some of the IOM, the International Organization of Migration, a recent study published in March or June of this year called Fatal Journeys. And the statistics are frightening. 22,500 people died or disappeared in the Mediterranean since 2014. And we all know, and it's been mentioned today, the kind of hostility that exists now in the social political vein, even across the European Union and across European Union membership, around the clamping down of EU borders, and that we know that the numbers of migrants are reducing, the numbers of deaths are actually increasing because people are having to choose much more dangerous routes to come into Europe. So what is migration, and who or what is a migrant? And I've deliberately it's quite provocative and kind of objective, subjective in a way of what is a migrant. And deliberately saying that because a lot of the speakers today were talking about the stigma. Obviously, the conference is about stigma and our unconscious or conscious ability to dehumanize people regardless. So I'll speak a little bit more about that in a few moments. But basically in Ireland there are different ways of migrants to get into the country. And I'm saying this conscious that my own group are refugees and asylum seekers that are accommodated in the centre where we have our clinic. So we look at the emigration processes and making the distinction between emigration and protection. The area we work in is in protection. And the 6 ways really of getting into the country are through the programs, the bilateral agreement programs between the European Union, national governments, and maybe the United Nations or the IOM medical program refugees, people who have to come, who are chosen to leave refugee camps in border countries who have medical situations. I have not yet come across somebody who has been brought in on the medical refugee program specifically around HIV. Ordinary asylum seekers who come into the country, family reunification program, the undocumented or no status, and then the Irish Relocation Protection Program, which is specifically set up by Minister Fitzgerald in 2015 for the Syrian in response to the Mediterranean crisis. So there's been a lot of talk today around the, I suppose what sociologists or people working in social and community area of work would call the intersectionality. And even Kate speaking there earlier on, Austin speaking, Tony earlier, and all the other speakers, the commonalities that exist within groups that are perceived to be on the margins. And really, in terms of the use of language, it's so important, and particularly in a climate when the social, political, and economic ideology is kind of hostile towards migration and migrants, that we're clear in our terminology and that we're clear in our understandings of who is a migrant. So I'm going to read the definition of migrant, keeping in mind what Austin was talking about earlier on around social construction, bringing me back to me heady days of college where you had to tease that stuff out. So the IOM define a migrant as any person who is moving or has moved across an international border or within a state, away from his or her habitual place of residence, regardless of 1, the person's legal status, 2, whether the movement is voluntary or involuntary, 3, what the causes for the movement are, or 4, what the length of stay is. So I think we can positively say that perhaps 100% of us here in this room have been migrants or are migrants, that we've all experienced that phenomena of being a migrant, and what comes with that, and what are the consequences for people. Just maybe to pause and think about that for a moment, and then add in the complexity of being a migrant living or affected by HIV. So all of those social constructed phenomena or elements, or whatever we want to call them, experiences of everyday life, and how do people navigate the day-to-day. And for people that we work with, it can be difficult, and it can be particularly difficult for a number of different reasons. And I suppose a way that society tries to get around that is categorizing people. And I would ask the question, who categorizes? What do we categorize, and for what purpose? And there are many different aspects that we need to consider when we're working within migrant healthcare. And the other thing really is that we don't homogenize all asylum seekers and refugees. And that's, as Austin was saying earlier on, and our own experience of working, is that we tend to create that stereotype and focus on the negative stereotypes. That we need to look at the diversity within the migrant community, within the refugee community, in the same way that we look at it within the HIV sector. Okay. Is that moving on there? I'm going to move on. So there's a lot of kind of controversy, sensitivity, political kind of walking around eggshells when we talk about the direct provision system. And I suppose the purpose of my being here today is to inform people, make people aware that there are people working within the agencies of the state, within other services such as the HSE, working with refugees and asylum seekers. And we walk a tightrope because we don't work for the Department of Justice. Our modus operandi is different. And if you're coming at it from a nursing perspective, there's lots of challenges in terms of our role and engaging and working with people. So where we're based, where our clinic is based, is out near the airport in St. Margaret's, and this is the Balseskin Reception Centre. It's the first phase of the direct provision system known as reception. And people would normally stay here for about 3 to 4 weeks, depending if people have chosen to come for voluntary health assessment and issues arise during a consultation. There may be reasons that we would advocate for them to remain longer. So it accommodates about 300 plus people, and it's in existence since 2002. I work as part of the Asylum Health Screening Service, and we're in there as part of primary care through HSE. So my own line managers would be the directors of public health nursing and assistant directors. So that's just a few photographs of Balseskin. I always encourage people, if they want to come and visit the clinic in Balseskin, please make contact with us and my details will be up. Because what we do in the clinic there is really about engaging in a primary care, community care model of offering health assessment for people. And over the years we've worked with, I see Rebecca here, Erin, St. James's, the Mater Hospital, and although we're providing health screening assessment, we're very much based in a transcultural cultural competence model that links with peer empowerment and support. And we're lucky enough to be able to convince the powers that be that we can continue that way, but it's not always an easy road. So why do we do what we do? Why does anybody go into the type of profession in health or social care? And particularly working with migrants, it's really about preserving the dignity of people in whatever it is that we do, whatever discipline we're working in. And what is dignity? And I think there's been a lot of talk about stigma and a lot of talk about what it is, the harm that stigma causes. And it's really where we just disregard, dehumanize, and pay no attention to the dignity of the person. So the quality of being worthy of respect, self-importance, pride, self-esteem, and self-respect, regardless of colour, creed, religion, sexual orientation, whatever. These are photographs, fairly recent photographs, from the Syrian border with Lebanon and with Iraq, and the Eli Etna, I think, one of the missions there with the kid, and one of the Navy officers. So migrant healthcare and vulnerability. I'm not going to go into this too much because it's stuff that you'll be familiar with around what people experience as part of the migration trajectory and its effect on their health and well-being. And I think the picture there, which is a very sad picture, taken from the Balkan Wars, I've been using this photograph since 2001 or 2002, and in some ways it's sad that that picture is mirrored still in other people's experiences across the world. But rather than looking at the sadness in it, it also looks at the comfort and the resilience of people, which we don't tend to focus too much on in migrant healthcare. There's a kind of a victimization element to how we approach. So, as I said there, why do we do what we do? Within the context of nursing anyway, and most healthcare professions, we have our moral and ethical obligations, our professional and our statutory and legislative obligations. And I suppose what's become more prominent for me in practice and in thinking and in education and raising awareness is how do we as healthcare professionals educate those that are coming up behind us? How do we inform multidisciplinary members of team about these factors and also the relationship with equality legislation, human rights legislation, etc. So we have to ask ourselves those questions around how we practice. And that exists in the context of provision of HIV screening and testing, that these are more than medical issues. And Maeve this morning and Mary earlier on, speaking about the quilt, made reference to the re-medicalization of the HIV sector as a consequence of, great therapy and pharmacokinetics and etc. But I do think we need to hold the mirror up now again, and it is great to see that the learning that has happened with the history and the archives, and that we can hold the mirror up and reflect on what's the way to move on in terms of social and cultural understandings of HIV, what gives people meaning and understanding and expression of, a positive expression of their experiences and healing. So basically in Balseskin, we offer a health screening, a voluntary health screening, which is confidential and separate to the asylum process. And this is where we straggle the lines sometimes in terms of people being dispersed or relocated to other centres around the country. And we have to liaise and advocate and argue with different people in different roles. And I have to say, in the main, we're fairly fortunate in that people do listen and we can help people from time to time. We have a social worker service now, which we did not have. It's in existence for the last 2 years. A primary care social worker. We have a specialist psychology service for refugees and asylum seekers. And then the nursing, medicine, public health and general practice. So just to give you an idea of stats from last year, the number of people accommodated in that year was 1,823, and we invited 1,600 odd. The number attended for health screening was 1,377. I'm not going to go through them all. We have a good uptake, 80 to 84, 85% plus of voluntary health screening. What has changed in the period of time since I've taken on the role as clinical nurse specialist is really a reflection of globalization and migration trajectories internationally, in that Balseskin, also to do, I presume, with limited resources post-bust, different cohorts of people were being accommodated in the centre, and we still have that, and you can see that from the slide. When I started initially, it was primarily newly arriving asylum seekers and refugees that were being accommodated. And if you look at the If you look at the countries of origin there, it's no surprise really that when you look at media and what's happening globally. Specifically around HIV, in the period of time we've been offering voluntary health assessment. These are the figures, they speak for themselves. What's interesting is the gender breakdown, 70-30 in terms of 70% female. And just doing a little bit of reading around some of the sub-Saharan African countries where the feminization of HIV is still very prevalent. This isn't a surprise. And it's also not a surprise when you kind of look at the countries of origin where people are coming from and you look at the global HIV pandemic. Anyway, in terms of the nurse specialist role, really there's 5 core components that we have to achieve or engage with as part of our role under the Health Act and the Nursing Act. And it's really around client caseload, education, advocacy, research and consultancy. And as I said earlier, we would do that through kind of a model of community development and primary health care and convincing those that it's important. So the links with HIV Ireland are key in terms of establishing peer support, peer education and awareness. Working with Erin over the years, we've come up with some good ideas and just practical, minimal funding required, but just good sense approaches to empowering people to work amongst themselves around prevention and support. AIDS and mobility. Years ago, I was the national focal point for AIDS and mobility, which was a great funded project through the European Commission, looking specifically at refugees and asylum seekers and mobile populations. And we would have done some work around developing resources within different groups at that time. Unfortunately, the money dried up, and the project and Ireland I don't think really picked up on it. We tried to influence at the time the National AIDS Strategy, the Subcommittee on Education and Prevention, and we did make inroads there, but I really feel coming from today, there's a new momentum evolving around how we look at all of this in terms of including migrants. 17% of the population, based on the most recent census, is now migrant born outside of Ireland, so We also need to look at the intergenerational, as Tony said this morning, the intergenerational element. So how prepared are we in moving forward around that? What's stopping us from doing that? I always argue it's our own ethnocentrism, really. It's around challenging our own ethnocentrism around diversity and even around healthcare and the provision of healthcare. And ultimately, it's about the hearts and minds engagement with people that results in change. Change is slow, very slow, but we're getting there slowly but surely. Why are we working in silos? Somebody else asked that question, and just to pose this really is important around immigration law. International and national immigration law is often the arena where human rights and national self-interest clash, and the principle of promoting the best interests of vulnerable groups can be overlooked, and that exists in terms of the intersectionality that I spoke of across the different areas of work. So I finish up there, Richard. Thank you very much. And thank you very much to the committee for asking me to speak as well, and my colleagues. Thank you.